Good afternoon. Welcome, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. This is the latest in our series of public health conversations. These events give us a chance to come together as a community to engage with issues that matter most to health. At these events, we welcome guest speakers who guide our discussion of key issues of the day. The aim is to inform a conversation that supports a healthier world. Thank you to everybody for being part of today's event. And a particular thank you to Meredith Brown and Alicia Noel for making this event possible. During COVID-19, we all had to adapt to a new normal. This new normal was forced on us by circumstances we could not control, and we worked collectively to navigate the challenge of the moment. As we now look to a post-COVID future, we have the chance to shape the next normal. Unlike the next 20 months, however, the next normal will be what we make it. We have an opportunity to apply the lessons of COVID to shaping a healthier world. It is towards this aim that we launched this series of events. We are pleased to be with you as we continue our discussion of how we can create a future that is far healthier than our past. Throughout the pandemic, we were faced with trade-offs. We had to balance safety through physical distancing with the freedom to go where we wanted, speak to who we wished, and engage in all the activities that characterize a full life. This balancing act has long intersected with the debate over civil liberties. Must we trade freedom for security? If so, how much? Or is this a false dichotomy and perhaps the matter is not as clear as a clean trade-off? Such questions have been front and center in this country ever since 9/11, and their importance was again brought to the forefront of national and global conversation during COVID. Shaping the next normal, then, means engaging with these issues. Here to moderate our discussion of civil liberties and health is Chantal Da Silva. Chantal is a freelance journalist working for NBC News. Her work has been featured by Newsweek, where she previously served as chief correspondent, as well as by CNN, The Independent, Forbes, the Bureau of Investigative Journalism, The Guardian, and others. Chantal is going to lead today's panel. We are very fortunate to have both our moderator and our panel. Everybody, thank you for joining us. Chantal, over to you.
Thank you so much, and thank you for having me here. It's an honor to be moderating this discussion on a very timely and important topic. The questions that we're looking at today around civil liberties and the prioritization of public health are ones that have been on my mind, and I'm sure on all of yours too. So without further ado, I'm going to be introducing our panelists. First, we have Professor Nancy Berlinger. Professor Berlinger is a research scholar at the Hastings Center, an independent bioethics research institute based in Garrison, New York. Her current research focuses on ethical and societal challenges arising from population aging, the bioethics of migration, and responding to and learning from the COVID-19 pandemic. Then we'll be turning to Professor Colleen Flood, a professor in the Faculty of Law at the University of Ottawa, as well as the University Research Chair in Health Law and Policy. She also serves as the inaugural director of the university's Center for Health Law, Policy, and Ethics. Professor Flood aims to push the boundaries of health law beyond its traditional focus to illuminate law's role in the broad web of relationships within health systems. Finally, we're going to be hearing from Professor Rakea Yerby, who is a professor and member of the Center for Health Law Studies at the St. Louis University of the School of Law. She is also a co-founder and executive director of St. Louis University's Institute for Healing Justice and Equity. Professor Yerby is an expert in racial health disparities who advocates for equal access to quality healthcare and fair wages for racial and ethnic minorities, women, and the poor. Thank you so much, all three of you, for being here. First off, we're going to be hearing a bit from each of our panelists directly. So I'm going to hand it over to you, Dr. Berlinger.
Thank you so much, Chantal. I'm going to share my screen and I have a few slides. So thank you all. This is a wonderful opportunity, and I'm truly honored to be here with such esteemed colleagues. So what I thought I would start with is a small introduction to the idea of bioethics and the idea of doing bioethics for different publics. Bioethics is an interdisciplinary area of scholarship, empirical research, practice, and education. It concerns what it means to be human and a member of society in relation to experiences of health, well-being, and flourishing, including and not limited to access to healthcare. Increasingly, bioethics work also focuses on non-human species, on habitats, and on global challenges such as climate change. Now, bioethics frameworks and recommendations, such as those that had to be generated throughout a public health emergency like the COVID-19 pandemic, often aim to clarify ethical, by which I mean right or wrong, dilemmas or challenges in healthcare work, research conduct, or policy investments and priority settings. Are we going in the right direction? Are we doing the right thing? Are examples of everyday ways that we think about these moral and ethical challenges at work and in our everyday lives. These and other domains concern foundational and practical questions about how to respect persons, how to prevent harm, how to support flourishing, how to mitigate health inequalities, and how to promote social justice. So these are all areas in which ethics work engages, although not necessarily all at the same time. And to one side here, I've given an example of the COVID-19 framework that my organization put together. We published the first edition on March 16th, 2020. So we had started work in late February when it was very clear how serious this was going to be in the United States. Our focus was on the United States, and our goal was to get an immediate framework into place for healthcare institutions that were accustomed to thinking about individual patients to respond to a public health emergency. We knew very little other than that they were going to have to plan and not just wait for a crisis. They were going to have to think about vulnerable populations, and they were going to be prepared to provide guidance to clinicians, to frontline clinicians, as we sometimes call them, very quickly in non-typical ways under conditions of contingency and often crisis. So that was the first task. And I want to also mention that Colleen Flood and colleagues created an incredible resource early in the pandemic. It's a book-length publication called Vulnerable, produced by the University of Ottawa Press. I still have no idea how they put that together so quickly, but it's amazing what people were able to do at that time. So here are some examples from the Bioethics Forum blog of the Hastings Center, my organization, from doing public health bioethics to doing bioethics in public, with the idea of things that extend into the civil liberties space. These aren't necessarily things that you thought of on day one of a public health emergencies, but they emerge in response to an evolving crisis with many, many dimensions. These are just from the past few months, and in some cases from the past few days. What warrants religious exemption in COVID vaccine mandates? Very hot topic in the United States. Vaccine mandates for healthcare workers, another very hot topic, especially here I live in New York City, and there have been mandates at the municipal level. There have been mandates at the state level, at the organizational level. So this engages all sorts of different workforces. There was a student perspective going back to college on universities requiring vaccination. A piece by a philosopher who's also the parent of a public school child saying, how do you reason in community settings such as school boards when the guidance that's being offered from your state conflicts with the best available public health guidance? How do you not just say, well, we don't know what to do, or this is the best we can do, or we're just following orders? How do you help people deal with competing sources of authority? And then a post that I was involved in as part of a group that I'm part of in New York State on the dilemma that we've experienced over many months, where we have a very highly vaccinated population who include long-term care residents, because they were in the highly prioritized 1A group, as we call them in the United States, who were still being isolated, not able to have meals together, not able to have visitors, not able to have social activities because of outbreaks among the staff in the nursing home. So we were looking at the ethics of overprotecting one group, being almost confined to barracks or confined to in a custodial way for their own protection concerning breakthrough COVID, to permit individual choice on behalf of staff. Now, vaccine mandates are aiming to correct this problem, but not without a lot of tension in the workplace. So to the questions that we were asked to continue to talk about for this event in concerning challenges and opportunities, here's my sense, one American in bioethics sense of challenges and opportunities that COVID-19 exposed in my field, in my country. I don't want to speak transnationally or globally, although we could certainly do that. One was that the consequences of structural problems in national, state, or local public health infrastructure, including deficits in trustworthiness and in public health communications, were experienced by organizations, hospitals, nursing homes, and others, by frontline practitioners, doctors, nurses, and others on the front line, and by vulnerable populations themselves. Adults, usually older adults in residential care facilities, people living with disabilities, people living in overcrowded housing, and many, many other groups, in ways that these practitioners, organizations, or of course populations could not fix or resolve. I think we understand in this country that we don't really know how to communicate about public health at all. But underneath that are deficits in trustworthiness and whether or not we should trust the person who is communicating with us. I think also a cultural emphasis in the United States on individual choice, which we see in bioethics in an emphasis on autonomy or self-determination in medical decision-making, but also in the larger culture in debates about masks and vaccinations that were absent in other countries. Means we have an underdeveloped idea of being part of a public and acting in the interests of public health. In terms of the question we were also asked to think about in terms of how to build a better next normal in this very complicated society, I have 3 suggestions. One is that we need to keep explaining the relationship between social justice and health equity, the equitable distribution of health-related risk and benefit. Rather than assuming that our audience knows what these terms mean or saying things like justice now or equity now or using them in kind of a slogan sense, we really do have to understand that this is not well known to people. This may not be familiar to them. I like, from a public health context, I like Nancy Krieger's formulation, very elegant. Social inequalities are embodied as health inequities. So we are going to see health inequity if we don't get at the root social inequalities. I think it's also helpful to identify non-clinical sites of health that matter immensely in the lives of people and populations. So we're not always focusing on the healthcare setting, and we should build and strengthen those sites. I'm very interested in housing as a site of health that determined COVID safety or vulnerability, in part because I do work on the consequences of population aging, and in part because I do work on immigrant health. And these are 2 groups that are often experience precarity in their housing. They cannot afford housing that is appropriate to their needs, affordable, accessible, and so on. So right now I'm working on a project with colleagues at the Harvard Joint Center for Housing Studies. It's the acronym for the study is COVID Recap. And we're learning from the COVID moment and from COVID pivots by mostly community-based organizations or public sector agencies to better align housing and services for our aging population and our care workforce. And this will help us identify public square issues, such as a willingness to change zoning so that we can build more affordable housing, that we can build accessible housing, to replace not in my backyard with less in my backyard, to have a preferential choice for openness to affordable housing, rather than assuming that this is something that is that communities should not want. So there's a lot of work to do, but it's quite interesting to learn from this moment. And finally, I think another important thing that we can do to build better is to build the next generation of public health scholars. we created a program at the Hastings Center called the Sadler Scholars. We normally have a residential visiting program, but the pandemic gave us an opportunity to be more creative and also to think about providing greater diversity, inclusion, and equity in bioethics research by encouraging minority doctoral students from underrepresented communities in health-related fields to be part of the Hastings Center community. So we chose 6 doctoral students from throughout the United States who are now part of a series of workshops, work in progress seminars, and also participation in the hybrid life of the Hastings Center as a research institution. So I think that's been a very important part of what we've tried to do to build our field and strengthen our field. Kiona Wynn, who I'm gesturing to here, is getting her PhD in population health at the Harvard Chan School of Health across town. So one of them does come to us from the public health sector. So with that, I will stop my share and I will turn it back over to our moderator. Thank you.
Thank you so much, Professor Berlinger. That was also fascinating, and I'm looking forward to discussing it shortly. We're moving in alphabetical order here. So next, we'd love to hear from you, Professor Colleen Flood. If you so choose. If Professor Flood is not available, or then if we could move to Professor Rakaya Yerby. Rakaya Yerby, that would be wonderful to hear from you.
Great, thank you. I think we actually lost Professor Flood. So I am so excited to be here, and thank you so much for having me. I want to share my screen. So as mentioned, I'm Executive Director and co-founder of the Institute for Healing Justice and Equity. And I am going to talk about systemic discrimination, particularly using the example of racism. And I always think that we need to think broadly about the questions that we have. So I will spend my time pushing us to think even beyond civil liberties and just rights. And so I want to start off by talking about COVID-19 discrimination and civil liberties. We traditionally think, particularly in the United States, that as individuals, we have certain liberties and freedoms, but that's an assumption that not everyone has. And so I wanted to show this example of the protesters in Michigan, really protesting mask mandates, stay at home, social distancing measures, and how they are treated versus an African-American woman who was not wearing her mask properly in the New York subway, who was taken down by multiple police in front of her child. And so I'm going to talk about systemic discrimination, again, focusing on racism, COVID-19, and really what we are saying when we are talking about framing this problem in terms of rights protections and civil liberties that not everyone in the United States seems to benefit from. And so what do I mean by systemic racism? That refers to a complex array of social structures, interpersonal interactions, beliefs, really about who is valued, who deserves protections, and it's used as a way to disempower and devalue other groups. It is about power, it does not require bad intent, and although there are multiple groups that are impacted by systemic racism, that are impacted by systemic discrimination, today I'm going to focus on racism, and I'm only going to focus on interpersonal, cultural, and structural. But before I turn to that, I want to talk about the ways that COVID-19 has already been misframed. And so we were asked whether we should even think about civil liberties, individual perspectives in terms of COVID. And to me, that is part of our problem, that we have tried to address COVID-19 through individual measures, through focusing on changing individual behaviors, which really ignores the fact that some communities, particularly employees, do not necessarily have the power to make decisions about whether they can social distance or not, because they are balancing the ability to live and still have a place of employment. And so when we think about COVID-19, we should have framed it in terms of population-based. How can we support our population rather than focusing on individuals? And I want to highlight why this becomes a problem. When we take a look at these workers featured here, all of them were deemed essential workers, but none of them were provided with the protections that they needed. I also want to highlight that traditionally, predominantly, a lot of the essential workers did not have the same protections rights as other groups, specifically if they were undocumented immigrants. We do not treat them as having civil liberties or even the rights to challenge the lack of protections. And so when we think about this, 55 million Americans have been labeled as essential workers. A majority of them come from healthcare and the food and agricultural industry. And research has showed that increased rates of infection and dying are strongly associated with being an essential worker. We see that across the nation, as well as in particular cities in Boston, Massachusetts, the neighborhoods that had the highest rates of COVID-19 infections were predominantly in neighborhoods that had a high rate of essential workers and a high rate of racial and ethnic minorities. And again, I want to highlight how this has disproportionately harmed people of color, particularly Blacks, who are occupying the top 9 positions, occupations that had a higher risk of COVID-19 infections. We can also see this in a National Nursing Union report that showed that nurses of Filipino descent comprised almost 32% of the nursing deaths from COVID-19, even though they only account for 4% of the nursing population. And then when we switch over to meat and poultry processing workers, we can see again that there's a disproportionate impact on people of color, undocumented immigrants, because those tend to be the ones on the front lines, but it doesn't just harm them. It also harms their communities, where we see a 51 to 75% increase in COVID cases in counties that have meat and poultry processing plants, as well as the entire United States. And so when we talk about civil liberties, we need to think really about how that interacts with racism and discrimination and our COVID-19 response. And so interpersonal racism operates through individual interactions, unconscious and unconscious prejudice. And we could see that in the implementation of a lot of the COVID-19 measures. Here are 2 different stories. One, the Nashville police arrested a homeless Black man in the first night of stricter downtown mask enforcement, while they allowed many tourists and people to continue to walk around. We see the same disproportionate impact and enforcement on a homeless man who left quarantine, but treated people with money treated very differently in terms of them leaving quarantine. And so when we think about civil liberties, the question I want people to ask is really, what are we talking about? Because civil liberties is not something that is enjoyed by everybody in this country. Furthermore, we saw this problem in New York, where there were social distancing, policing, and we see that initially out of the 40 arrests, that 35 of the arrests were Black 4 were Hispanic and 1 was white, and that a majority of the enforcement again focused on predominantly Black and Latino neighborhoods. And so when we're thinking about civil liberties, that is not something that is enjoyed by everybody in this country. Furthermore, when we take a look at the COVID-19 response here in the United States, in this discussion about protections, we see it discussed very differently when it comes to racial and ethnic minorities. And this coincides with cultural racism, right? The presence of societal beliefs and customs that promote the concept that white culture is superior and denigrates other cultures. We can see this, a statement made by Ohio State Senator and physician who questioned whether African Americans' increased rates were linked to some cultural belief of or action of not washing their hands properly. We know that COVID-19 was initially called a Chinese disease, and we can see many governors, not just the Texas governor, blaming the increase of COVID-19 on migrants as he removed the mask requirements and has since tried to battle against vaccine requirements. We also see that in Florida happening where last year, earlier in the year, we saw students flocking to Florida and spring break, which was associated with the increased rates of infections from the Delta variant. But instead, the Florida governor blamed it on the migrant workers down there. We see it in structural racism in the ways that laws, policies, and practices are used to structure systems in a way to advantage the dominant group and disadvantage racial and ethnic minorities. And even in the discussions about vaccines versus those who have power and those who don't, right? There were several states that whites were going to bring lawsuits because they didn't feel that they had fair access to vaccines, that instead it was going to racial and ethnic minorities. We see a doctor in Colorado having their vaccine authority canceled because they were trying to ensure equal access to racial and ethnic minorities. But it plays out very differently when those who are prevented from equal access to vaccines are people of color. And we can see this in Missouri, where if you see right here, our governor sent 2,000 doses to a place that only had around 200 people, but was not willing to send those doses to predominantly Black cities, Kansas City and St. Louis. And in fact, those cities went 3 weeks without doses as the governor shifted those doses to places that did not have enough people. And so with that, I'm going to stop. Just want to highlight some of the work that I have done previously throughout COVID-19 on this. And again, just want to highlight that when we begin to ask a question about should we balance individual rights against the needs of the population, we have to be careful because even framing it that way assumes that everybody in this country has individual rights that we recognize, and they don't. And so really we need to begin the discussion about how can we work together to best stop the spread of COVID-19 and to protect those who are vulnerable because of current and historical issues of discrimination. So with that, I'd like to say thank you, and I look forward to your questions.
Thank you so much, Professor Yerby. Now, without further ado, we'll move on to Professor Flood.
Oh, hi, everybody, and I'm so sorry about the technical glitch earlier. It's really my great pleasure to be here, and thank you so much to the organizers for inviting me to participate on such a terrific panel. You might be able to pick up from my accent that although I'm speaking to you from Ottawa, Canada, I'm not originally from here. I immigrated from New Zealand, and I just spent 7 months in New Zealand on sabbatical. So my perspective in New Zealand, I'm sorry. So my perspective on these issues are, shaped by my two countries of Canada and New Zealand. I've taught for 15 years or so in Canada a course called The Law of Modern Day Plagues. And at the heart of that course is really a discussion often of trade-offs between concerns for civil liberties against conceptions of public health. And when we think of many of the great public health interventions of the last century, such as warning labels on tobacco products, restrictions of being able to smoke tobacco inside, seatbelt laws, fluoridization of water, childhood vaccination, helmet laws, all of these laws we know have saved millions of lives over time, but they do raise issues about their impact on civil liberties. So if we come to the COVID-19 pandemic, it's swept every continent in 2020, causing fear, illness, and death, with nearly 5 million lives lost worldwide at this time. And the devastation has not only been from the virus itself, but from the precautions taken to prevent further devastation, including job losses, business failure, school closures, mental health suffering, domestic violence, healthcare postponed or denied, and so on. And we sometimes describe these the costs of this as the collateral damage of the precautionary measures. And yet, despite the enormity of the suffering that we've experienced from COVID-19, and that flows from the disease itself, there is a vocal minority across a number of jurisdictions that protests that measures taken to slow the march of the pandemic infringe civil liberties and can't be tolerated. Now, there are always those groups in society, but undoubtedly the sheer scale of the pandemic and the cross-cutting societal measures that have been taken in response have fueled the ire of these groups, which are a mishmash of conspiracy theorists, anti-vaxxers, some true civil libertarians. And social media has largely supported echo chambers of ourselves, where individuals holding, for example, anti-vaxxer viewpoints find themselves validated by ever more content directed to them that confirms their biases. So from all of this, I want to make 4 brief observations today. First, many claim rights, but they do so in a vacuum, a right without legal justification. And we see this frequently in the Canadian context. So folks in the media claiming, I have a right to cross provincial borders, or I have a right to cross into the border of Indigenous people's land to access my cabin or my cottage, or a right not to have to be in a lockdown or obey a curfew. And in Canada, that is clearly not the case. We don't have absolute rights, and there is a balancing that occurs. For us, it's done explicitly through Section 1 of our Charter of Rights and Freedoms that, in essence, says that government is able to defend what might otherwise seem to be an infringement on the grounds that it's reasonable and proportionate. And so far, the courts to date have been relatively forgiving of the decisions that governments have made in order to quell the effect of the pandemic. The context of the pandemic matters a great deal to whether or not one can claim an actual right to do X or Z. So I think the new normal going forward might mean that we need to have closer attention to how claims are made about rights, and they're bandied about not only in the media or by different individuals, but also by legal scholars. I think we might need to really start to examine more closely this kind of discourse. Secondly, many of those claiming the civil liberties infringement frequently claim that the collateral damage that I mentioned before, the impact of the precautionary measures, outweighs the disease itself. That is, the costs of the lockdowns, the health delays, and so on are worse than the COVID-19 disease. And sometimes, as we've just heard, much more serious claims are made about the disproportional effect of precautionary measures on those whom societies have historically marginalized. And I have much more respect, of course, for these kinds of claims, in particular, for example, the effect of differential enforcement of precautionary measures against racialized groups. But when it comes right down to the question of collateral damage versus letting COVID-19 rip, we know that if COVID-19 is allowed to reap its deadly course, that the victims will be predominantly from these very same groups as well. The third point I want to make is that there's always a tension in considering the trade-offs between civil liberties and public health, in that what is the evidentiary basis of the public health measures? And, so how do we know that what the government is doing is actually needed in order to achieve X or Y or Z? And that's really particularly difficult as a new virus emerges, and we don't really know its origins or how it will actually spread. And so governments and public health officers are often operating in the dark, as it were, not understanding exactly what will work. And, the unknowns of this means that government action can't be justified by some randomized controlled trial or, our gold sort of standard of evidence. And I think this problem of, the changing science and different views on the science of COVID-19, that different views, for example, between the World Health Organization and nation states, between public health officers, even, within the same jurisdiction, I think we have to be clear that these differences, even although they may well be valid, have undoubtedly fed the machine of conspiracy theories and anti-science rhetoric. So I think we're going to have to really think about this quite a bit more going forward. How do we communicate science? How do we restore trust in science? And yet, how can we be able to, for public health officials to be able to change their mind and respond to emerging science as it happens, particularly in the course of the global pandemic? And my fourth and final point is really, again, building on the last speaker, is that the claims in civil liberties do nothing to help people if their governments are not taking steps to protect the people's health. So we have had examples here, as you have as well in the United States, of provinces and states opening up far too quickly, abandoning restrictions and measures, not supplying PPE to the people they really should be supplying PPE to. Sometimes they do these things to placate those who put their political constituents, who put liberty above health and life of others. And sometimes it's in a misguided attempt to try to spur business and the economy. But the ability of people harmed from governments to be able to take some legal recourse against those governments is very weak in North America, both in the US Constitution and in the Canadian Constitution. There really is little avenue to argue for some kind of positive right to healthcare. It's also very difficult to bring any kind of private law action, for example, in tort law, against government's failure even to do the things that they said that they would do. Moreover, in a couple of provinces here in Ontario and Alberta, governments have passed laws to make it more difficult for patients and their families to sue, for example, long-term care homes or other businesses, changing the standard from ordinary negligence to gross negligence. So not only is it more difficult to sue the governments, it's also more difficult already difficult to sue the governments. It's made it more difficult to sue private entities that may be responsible for harm. So to conclude, I think, to save lives as we come into the fall and winter now in North America, Depending on vaccination rates and other measures, it may well be necessary for governments to take more precautions. But I think for people to worry that such precautions are the new normal should not be so worried. The reality is if that there is insufficient evidence for those precautions, then government action in this regard can't be constitutionally defended. And the courts will be an important mechanism for holding governments accountable for striking the right balance between civil liberties and public health objectives. I do hope, though, that going forward, as we think about a new normal, that this will include some reflection really on the indecency of anti-vaxxers arguing that their civil liberties include the right to picket and harass school children or people trying to get into hospitals, but there is so little legal recourse for those who are harmed by the lack of government action or inept government action to protect them and their families from COVID-19. So I really do truly hope that a silver lining of the pandemic is that we have a much more serious evaluation of how to realize the right to health and not just the protection alone of civil liberty claims, as important as those are as well. So thank you very much for your time, and I really look forward to the conversation with the panel.
Thank you so much for that. And thank you to all three of our panelists for sharing those brilliant presentations. It's been great to hear your perspectives grounded in your own distinct bodies of work. I have a few questions for our panel, but I want to remind our audience to please submit your questions to the Q&A box. You'll find it just right at the bottom of your Zoom screen there. Until then, Professor Yerby, my first question would be for you. During your talk, you spoke about the disparities that immigrant workers face, as well as the fact that Black and Hispanic workers disproportionately occupy workplace roles that put them at risk for contracting COVID-19, while also facing difficulty accessing vaccines. Yet much of the focus around the discussion on civil liberties when it comes to COVID-19 tends to come from the side of those who are against vaccinations and mask mandates. Do you feel that the media and public have done a good job of seeing and portraying these disparities as civil liberties issues, or have there been some failings there?
Yes, thank you so much for that question. No, we haven't done a good job of recognizing them as civil liberties issues. And I know I am one of the lawyers on the panel. I hate to just focus on civil liberties because it is so much more. As Professor Flood said, right, it goes to the very rights, positive rights, the rights to healthcare that really have we seen the problems with during COVID-19, and it goes to structural inequities. And so for me, we do a lot of blaming of the workers, of undocumented immigrants, of the poor for the reasons why they have COVID-19, and then punish them if they're not complying with things that maybe they can't. But then we see people walking around yelling, and as Professor Flood said, even at schools, and they are not, there's no accountability for that. And so let me just give you an example. On one hand, we're trying to penalize, perhaps in New York, right, people of color for not wearing masks, not social distancing, but we're not holding employers accountable for not implementing those protections for workers. Under Biden, we have implemented that for healthcare workers, and we see some movement with some states that are not doing that. But there's still a whole host of workers, right? Grocery store workers, teachers, agricultural workers, meat and poultry processing workers who are not protected. And so I know in my talk I didn't mention civil liberties because I don't like that, because then it again focuses on limitations that we have in the United States of only sort of these negative rights for the most times, and it does not protect the majority of the people who need the government to protect them.
Thank you so much for answering that so succinctly and well, thank you. Yes. Professor Flood, you have also spoken about, the importance of instilling trust in the science. And of course, throughout the pandemic, we've seen the science doubted across communities around the world, including by governments around the world. I know that you're based in Canada, and I'm Canadian myself, but no bias here. But, you know, in Canada, we have seen lower rates of vaccine hesitancy and, you know, a relatively fast pace of vaccine uptake compared to the US. Do you believe that any of that has to do with government, the political sphere? What is really sort of driving that disparity, would you say, between borders?
That's a really interesting question. You know, the United States is a huge country, and there's great variation between areas in terms of uptake or not, just as we see in Canada, but more so, I think, in the United States. I think that we sometimes don't really appreciate as much the sort of the normative impact of governments saying that things need to happen. So, you know, that measures should be taken, that we're taking COVID-19 very seriously. And I think that helps to create a sense of community and solidarity, and that we're all in this together. We need to work together. We need to protect each other. We need to protect ourselves, but that's not the end of it. We need to protect each other because we're all in it together. And I suspect there is just more of a sense, probably from a nation perspective. And again, this is not, you know, subnationally. There are obviously many differences, and you will see examples of much more solidarity in subnationally in the United States. But perhaps from a nation perspective, we would say that Canadians have more solidarity, particularly perhaps around healthcare, where we have enjoyed not far from perfect, but universal public health insurance, you know, since the 60s. So I think there is that may explain it. But you know, I was very impressed actually how Canadians kicked in the doors here to get their vaccines once they arrived. And you know, I think I compare that to New Zealand, where perhaps people have been a little slower, but that's because they haven't lived in the shadow of fear of death and disease. So there hasn't been any disease there. There has been disease in Canada. We all know people who have had COVID or know of people who have died. So, you know, there's nothing like a hanging, they say, to focus the mind. And that certainly has been a spur as well. And we've seen what's our neighbors to the south, right? So we've seen the very high rates of death and disease there. And I don't think we wanted that. So there are a bunch of different things. I'm sorry, it's a bit of a rambly answer, Shanta.
It's a bit of a rambly question. It's a hard question to answer. So I appreciate you taking it on. Thank you so much. Now, Professor Berlinger, I know that during your talk, you stressed the importance of continuing to stress the relationship between social justice and health equity. Do you, during the pandemic, you would think that relationship would kind of have, you know, become quite well known and become sort of obvious, right? But in many cases, it doesn't seem to have unfolded that way. Why do you think that is? Why are we kind of regularly missing that relationship?
Well, that's a great question. And I think there's a number of different reasons. I really spent a lot of time this past year talking this through with colleagues who are political philosophers, clinicians, and others. And I think some of this predates the pandemic context and also predates the racial reckoning after the murder of George Floyd, which is another strand here that it's very important to talk about in the United States in particular, but also in other countries, is that sometimes including in bioethics and in other areas, we have this kind of slogan idea like, well, health justice now, you know, just like, well, of course, everyone should want that, or universal healthcare. And then we look at Canada, we look at New Zealand, we look at Denmark, and we say, well, we should just have that. That would be a good thing. But we don't really unpack it. And I was talking with a colleague who Professor Flood knows, Sridhar Venkatapuram, who's a political philosopher, a scholar of global health justice. And he said, I've been saying, even though he's written a book called Health Justice, he's saying, I'm talking about social justice, because we need to talk about things that are socially actionable and not just limit our scope to health or healthiness, because we leave out so much of human life if we just limit our scope. Sometimes we need to talk about health, but we need to talk about all of the things that are going on in our society that affect a person's health, well-being, safety, ability to stay alive, ability to flourish, ability to have opportunities for their next generation, and on and on. So I've taken that to heart quite often. And I also like what social epidemiologist Nancy Krieger says, that the relationship between social justice and health equity is that social inequalities are embodied as health inequities. So it's not just one thing where you see like a slogan like it's going to be our justice and equity initiative or something. You need to understand how justice works in society, and then how that plays out in the distribution of risks and benefits in a society. So you can analyze things at an equity level to say we're treating this group, they're exposed to more risk. Essential workers are being exposed to more risk relative to people who can work from home. So whenever I'd see an article that said, well, we're all at home now, like, no, we're not all at home now, as you're accepting your delivery or whatever it may be. But there's also, that's inequity. One group has more benefit, the other has more risk, but there's an injustice because it further hardens the stratification of social inequality in these societies by saying, well, my job's worth it and it's important to protect me, but that's an immigrant job, and it's, you should be lucky to have a job, and I really took to heart what Professor Yearsby was saying. I'm the non-attorney in the group, but the idea of it really matters who gets respect as a person in a society. In my discipline, we keep thinking, oh, the problem is we keep talking about autonomy. We keep talking about personal choice. And that's what leads everybody, well, not everybody, but a lot of people to say it's my right, it's my choice. And then that becomes the dominant narrative for journalists when they call me and they ask me, what about these people who say it's their right not to get vaccinated? They're right. But we've already framed this in terms of who is a rights bearer and whose rights don't we care about. But at the root of it is, who don't we respect as a person and whom don't we respect as a population? And so this is a very long answer to the question of why is it so important to keep clarifying what we mean by social justice and what we mean by health equity.
Thank you so much for that. Really appreciate it. Professor Yearby, as Professor Berlinger just noted, this pandemic did unfold in the midst of a national and international discussion around racial justice in the wake of George Floyd's death. One subject that's come up repeatedly throughout the pandemic is vaccine hesitancy. And there has been, a lot of headlines and a lot of focus around minority groups experiencing vaccine hesitancy in the US and other countries like the UK and different parts of the world. Do you feel, in the wake of this discussion, as an expert in racial health disparities, do you feel that this was well framed? And do you feel that it put the onus on these communities, or do you feel that particularly in the midst of this national and international discussion, there should have been more of a focus on how to relieve that vaccine hesitancy?
Thank you. And I will definitely answer your question, but I also know Professor Flood had her hand up, so I'm going to answer your question first. Yes, I had written about this early on before the vaccines became available, that we need to be careful about the language about hesitancy, because then we only focus on one incident, right? So we focus on Tuskegee, but we don't focus on how people have been treated throughout the pandemic, which is so important, right? So the fact that you as an immigrant worker, as a person of color who has been denied a mask, who has been denied paid sick leave, who has been required to go into work and be sick, then that means that you're not necessarily going to rush to go get the vaccine, particularly to continue to work for an employer who does not value you. And this question about get the vaccine and you'll be protected, it's for everybody, but you're sitting around and looking and the resources are not for everybody. We know that Latinos were turned away in Indiana, North Carolina, and various places from getting testing and treatment, being asked to provide their ID. And so when we think about hesitancy, it's not just based on getting the vaccine, it really is in response to how you are treated and devalued. And if we are not going to discuss that, then we're never going to get to the point where people are being vaccinated. I want to highlight too, is that we talk about it very differently as well, about sort of the anti-vaxxer movement, which tends to be thought of as whites, educated or uneducated, poor, middle class, and the discussion we have about racial and ethnic minorities. I don't know why, because the whole point is that we haven't done enough to support people and to get them to understand that it is about all of us here. And so we are working together for all of us. And so if we could frame it a little bit more in terms of why everybody may have some wish to hold back from getting vaccinated, that would be much better than separating out as if that there are some major cultural or differences between people. Everybody has a different reason, but we need to support people to get them to understand that it is so important and to provide what they need to be able to do it. The last thing I would say is that, you know, even with the vaccine mandate of some workers, our response has just been they don't understand. But we rarely ask, do they have time off to actually go get vaccinated? Do they have paid sick leave in case they suffer some side effects? We are not asking any of these questions, and we need to.
Thank you so much for that. I'm so sorry, Professor Flood, I missed your hand up. So.
Oh, no problem. No, I just wanted to jump in to say, to respond to both my panelists. One of the things I wrestle with is with, for example, the differential enforcement issue. So targeting, visible minorities, people who've been marginalized. What can we do from a legal perspective? And what I find is that that our legal mechanisms are impoverished, to respond to that. So I've been trying to sort of convey the idea that we have sort of fairly robust protections of civil liberties. And I worry that they can be weaponized, those kinds of protections, to actually prevent the efforts that governments need to do to protect us all from COVID-19, but particularly for people who live in poorer socioeconomic conditions, who are more likely to suffer and die if the pandemic takes hold. So when the civil liberty claims started to emerge, and they did, all over the place here in Canada, I was really worried that that they would be successful and that they would roll back government efforts as haphazard sometimes as they were to try to protect people. And then what I heard from some of my colleagues, was a concern, though, that some of the precautionary measures, as you've mentioned, would be differentially enforced. And I found that a really hard conversation to have, because on the other side of the coin, I could see that if those measures weren't put in place, more people would die. And for example, on the question of vaccine hesitancy and vaccine passports. I've been a proponent of vaccine passports here in Canada, and we've been really worried about what that would mean from the perspective of differential uptake, not as much uptake or concern by some groups that have been marginalized by society. But on the other hand, I feel that looking at, given the pace of the pandemic and the people that would die, essentially I take more of a utilitarian calculus here that, that we can't wait, we need to do it. And moreover, that I find that the law itself doesn't help us attend to that problem. Right, the Constitution itself, and I think it's the same in the United States, it doesn't help with this issue. So we need more robust and better legal structures to help deal with this issue of the police beating up on Black citizens, on the homeless. We need mechanisms for this. And we also need more robust mechanisms for a positive right to healthcare. So I'm sorry, I'm sounding like a pastor at a sort of a church or whatever, but there you go. I just felt I had to say that.
Thank you so much for sharing that. And vaccine passports were definitely something I wanted to discuss. So I really appreciate you bringing that up. I'm actually based here in the UK, where in England, the plan for vaccine passports was scrapped. And, we have seen, due to multiple reasons, our COVID cases rising, our daily death rate on the rise. And, part of that has been due to vaccine efficacy slowly wearing off as time goes. Our booster rollout has not been as speedy as it could have been. And, we've obviously got almost zero measures at the prevention of the spread of COVID here in England in particular, but also across much of the UK. So I did want to ask, and perhaps I can pose this to Professor Berlinger before we move on to the audience. And please, folks, if you have any questions to submit, please submit them, because I don't see very many coming in. So I'd love to hear your questions. But Professor Berlinger, I did want to ask you, do you feel that the vaccine passports are a good approach at sort of encouraging vaccine uptake, or do they risk shutting some people out who do not, for whatever reasons, have access to a vaccine?
Well, we are definitely in an experiment in that in my city, in New York City, because they are mandated to show they're not really called vaccine passports, but you have to either show your card, a photograph of it, or you can use a couple of different apps in a number of different settings, such as restaurants, eating in restaurants, which over the summer you hadn't. It was more of an honor system kind of a thing. And then I think partially it had to do with nervousness around the reopening of school and also around the reopening for tourism. Because when you consider somewhere like New York City, as you want people who are willing to buy plane tickets, hotel accommodations, and a lot of tickets to Broadway shows, which are quite expensive. So if people are going to commit thousands of dollars that they might not get refunds on, you had to make sure they were feeling like their risk was acceptable. So all of the major cultural institutions require vaccination. The other night I went to see a dance performance, and there's a line where you have to show that it's you are vaccinated and that it's so you show your driver's license as well. Then you go in to the theater. And this is the idea of helping people to feel comfortable with sitting shoulder to shoulder for hours. So I can understand the business side of that. Like, I don't know if the cultural institutions protested all that much, because they're like, we need these houses open. We need people to be willing to come and sit here. And on the other hand, this is definitely reinforces a two-tiered system, that if you don't have proof of vaccination, you cannot buy a ticket to that event. You cannot go sit inside that restaurant, and it's getting colder here, and so on and on. And one of the things that I've been noticing in some of the commentary is, what are the off-ramps? When do we say we're going to roll back some of these? And there's been a lot of attention to, like, when do governors have to give up their emergency powers? So this is kind of nice to have emergency power, but there has to be a rollback on that. Or what should the local metrics be in terms of infection rate, in terms of hospitalization, where you say it's safe, it's as safe as we're going to get it. but now we can roll that back. But I don't know when that's going to happen. I mean, just here in my city, which is the largest city in the country, we have a mayoral election coming up. We're pretty sure who the new mayor is going to be, but some things may get kicked to a new administration, not for epidemiological reasons, but for political reasons. So it's really hard to give an open and shut case about I'm vaccinated. So, I kind of can absorb the idea of a vaccine passport very quickly. But I also teach at a majority minority college where most of my students are working class. And I know they have very mixed views, and they don't have the same freedom of the city that I have right now.
Thank you. And just quickly, has having that dynamic with your students and with your colleagues, has that shaped your perspective? Has that changed your perspective at all?
Mine, I find that no matter what my topic is, my course is on migration, but I make time for this in parts so that people can talk about it. Because a lot of my students, they might work in home health aid, they might work in service industries. They are very subject to mandates in their they're definitely in the essential worker class. And so they have feelings about what they've experienced, and they're evolving feelings. Like some didn't like the mandate, got vaccinated on the last possible day, and now feel more relieved. And so you're dealing with these complicated feelings. Some say, I just cannot trust it. I just cannot trust. It's this feeling of, I cannot trust the system that is asking me to do that. But so you make space for the conversation, even if you can't fix the problem. I also understand in a city that relies so much on tourism, even though I'm not a restaurant owner, or I don't run a Broadway house, or I'm not responsible for anything on that side of my city, I know it's a reason why people come to my city. And so I can understand why it's like, we'll never be able to reopen a performing arts venue because we don't have a lot of public subsidy of the arts in this country. So it's really dependent on people buying those tickets. So we need to communicate those things. But I do think we do have to work toward off-ramps. I was in Denmark last month, and it was remarkable to be in a society where people speak of COVID, they call it corona, in the past tense, and where any teenager can tell you what the public health policy is. Now, they have lots of testing. They have it's pegged to strict indicators, but they are a post-COVID society and not for wishful thinking. They've actually undertaken and achieved a certain level of community immunity, and they have all these guardrails in place that everyone understands. But as an American who lived in Denmark, told me, she said, as soon as you call something public health in this country, people will say, I understand and I will follow, because there's high trust in public health, which is why people also stop at every traffic light, even if they see no oncoming traffic on their bicycles, because it's a public health issue. Whereas a New Yorker would just speed right through. So those are some of the reasons why you can't just take something that works in one country and feel that it's going to be a solution for another country. But it's very interesting to see differences like at that level.
Absolutely. And Professor Yerby, I think you wanted to weigh in on this as well.
Yes, and I love what was just said in comparison to different places, right? And so when you look at my state, our governor has passed, and our legislature have passed laws to not allow places to implement a vaccine passport, for the noise that just went past. But, and we also don't have a mask mandate. And in fact, the governor, the attorney general has fought mask mandates. And so I think what was said is so key, is that you have to understand that they all work together, that you can't just have a vaccine passport without also the protections of the mask mandates, the testing, and support for all the people who need it. But the key really goes back to what Professor Flood said, is that we buy into this. And what Professor Berlinger said too, right, is that when people know that we're in it together, public health, then we're more likely to do it. But part of that is rebuilding trust. And so I just want to highlight the work of Professor Lindsay Wiley, who is an American university, who has talked about the need to be explicit and clear about some of these off-ramps, about when we're going to allow for people to move out of COVID-19 out of COVID-19 measures would be great. But I feel like so many of the states have already rushed to getting out of COVID-19 while we're still in it. So we need to be clear about those things, about those goals, and then perhaps people can start trusting the government again.
Thank you so much for that. We do have a few questions coming in now, so I would like to pose this question, and I think it'll be interesting to hear from Professor Flood. How do we balance reinforcement of public health measures?
How do we balance reinforcement of public health measures with civil liberties, do you think, is the question?
Yeah. How do we balance reinforcement of public health measures against, yes, the protection of civil liberties?
I think that public health measures, when you're in a pandemic, we're usually thinking of applying some version of what we call the precautionary principle, because we're dealing with, potentially thousands, millions of people who can suffer and die. So even if we don't have perfect evidence, we take action, and I think the precautionary principle, though, requires as much transparency, that that the evidence that is available, that you discuss it, you make it known, and that you reevaluate what you're doing as the evidence evolves. And that where you can, you are as respectful as you can be of civil liberties, of individual autonomy. So these things are, I think, reconcilable. I do get a bit worried where I see public health officials, I think, unduly worried about things like civil liberties claims, and they're not lawyers, and they're responding to these issues as if they are. I think they should stick to their knitting, which is public health, and they should focus on that, and let the lawyers worry about if they've gone too far or whatever. So, but I think there is a balance that is struck. The courts will test this. They will say at various points, look, you've gone too far. You don't have enough evidence for X or Y or Z. But as I keep saying, I'm sorry to harp on about it, the bigger problem is that there's really little ways that we can make governments do a better job. So whatever sort of melange of public health initiatives you think is the right mix, vaccine passports, vaccine mandates, mask mandates, social distancing, curfews, lockdowns, wherever you are in that kind of mix of the pandemic, what rights do we have as individuals to actually ask our governments to get off their butts and do that? And when they fail to do that, what can we do? I mean, you look at a country like Brazil, where the sort of widespread deaths and suffering, the president there seems to have been actively promoting, COVID-19, like, let's all have these, parties and get infected and yeehaw kind of thing, causing terrible amounts of suffering and death. And, now there is a move to sort of potentially criminally prosecute him. But to me, that's too little too late, right? So, and the same with governors that are eschewing known public health measures. What can you do apart from voting them out at the ballot box? Sure, is there not some kinds of legal remedies that we could look to or start to develop in post-pandemic? In the new normal.
Thank you so much for that. And very quickly, Professor Yerby, if we can, I know we only have a minute or two left, but I just want to get to this last question. What do civil liberties mean in a society where there's intrinsic and deeply rooted disagreement on justice? What does that mean?
Yeah, it's such a broad question, and I don't know if I can answer it. But to me, what civil liberties means, perhaps, is going back to what Professor Flood said, and to be free from incompetence and from actions from your government that actually increase your risk to die during the pandemic. And so, instead of just focusing on, I don't want to wear a mask, we should be focusing on what are you doing to help me, and not setting up roadblocks so that I could actually get a mask as a healthcare worker, so that I could actually get paid sick leave.
Thank you so much. And thank you to all of our panelists. I feel like this discussion could go on all evening and I'd be here for it. But I just want to thank you all. And I want to thank our audience for joining. Now I'm going to turn it back over to Dean Galea.
Well, let me echo thank you. So, we've had many of these conversations now, and one is always careful about saying this, but this may have been the most interesting one. I can think of actually nothing more important than the question of civil liberties in the context that we're in right now. And Professors Yerby, Berlinger, and Flood, thank you for really outstanding presentations. I saw one of the comments, somebody said, thank you for different but highly complementary presentations. And I actually thought that was exactly right. I thought the other presentations were complemented one another and activated a different part of my brain as I was thinking about this. Chantal, thank you for expert moderation. And thank you for all the work that you do and for teaching us and for helping the world get to the next normal. A gratitude to our audience for being part of this and for asking interesting questions. Everybody, have a wonderful afternoon and a good evening. Take care, everybody.